Commissioners, we are now live.
Good afternoon to my fellow commissioners and also to those who are tuning in to the live stream. We are going to begin today's meeting with a vote to enter into a confidential executive session. We expect that the board will return to our public meeting at approximately 1 p.m. Our first order of business is to review and vote on the minutes from our last board meeting, which was January 16th, 2025. And can I turn to you, Colleen, to manage our vote?
Absolutely. Do I have a motion?
So moved.
And a second. Okay, great. Calling on each commissioner present, starting with you, Madam Chair.
Aye.
Vice Chair Cohen. Yep. Commissioner Castiel.
Aye.
Commissioner Coughlin.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Mastrogiovanni. Commissioner McGregor.
Aye.
I don't believe Commissioner Sullivan is here yet, or Undersecretary Mahania. So we can proceed to the next vote.
Thanks so much.
Welcome.
We will now vote to enter executive session.
Okay, great. Do I have a motion?
So moved.
So moved. And a second?
Second.
Okay. Madam Chair, how do you vote?
Aye.
Vice Chair Cohen?
Aye.
Commissioner Castiel?
Aye.
Commissioner Coughlin?
Aye.
Commissioner Cutler?
Aye.
Commissioner Foley?
Aye.
Commissioner Mastrogiovanni? Yep. Commissioner McGregor?
Aye.
Okay. And there's the vote. We will now move into executive session. Plans to return at a
Good afternoon, Commissioners. We are once again live on YouTube.
Thank you. And welcome to those of you who are joining us on the live stream as the commissioners return to a public session from our executive session, and we appreciate your patience. We're going to start by talking through the agenda for this afternoon's public meeting. We're going to begin the meeting with a presentation from the Health Policy Commission's Research Department on hospital capacity trends through June 2024 and our initial findings from a report on behavioral health-related emergency department boarding. We'll then review the preliminary report on the cost and market impact review of the proposed clinical affiliation between Dana-Farber Cancer Institute, Beth Israel Lahey Health, Beth Israel Deaconess Medical Center, and Harvard Medical Faculty Physicians at BIDMC, and the related construction of a freestanding adult inpatient cancer facility. The commissioners will consider a vote to release the preliminary report publicly. HPC staff will then provide an overview of advanced guidance that the HPC will be issuing regarding updates to the Notice of Material Change process for the recent legislation signed by Governor Healy. And then the meeting will conclude with agency updates in our executive director's report. With that, I will turn it over to David Seltz to introduce our first topic.
Thank you, Chair DeVoe, and welcome again, commissioners and members of the public watching on YouTube. I'm going to just introduce Laura Nasuti, who's going to be leading this research presentation. We had originally planned to present this at our December meeting and unfortunately ran out of time, but I felt it was important to return to this topic and give it the opportunity for the board to hear and to ask questions and provide your perspectives as we work on a report to the legislature on behavioral health emergency department boarding. But more broadly, I would say that this issue of hospital capacity is absolutely front of mind, not only to the HPC, but to many other state government agencies and the public. Seemingly every other day, there is a story of long wait times to be able to get the care that is needed, long wait times in the emergency department. And so we felt it was really important to use our objective data to try to provide some more insight into what is driving these trends, and also with the goal of perhaps having some policy recommendations later in this year that we can provide to the legislature and to the market to help alleviate what we're seeing as clear bottlenecks within our healthcare system that are impairing the patient flow and impairing patient care in many cases. So with that brief introduction, Laura, please guide us through our research here.
Okay, thank you so much, David. Hello, good afternoon, commissioners. Like David mentioned, I'm going to be discussing some of the results from our behavioral health ED boarding report that is in development. First, however, I want to share some findings on overall hospital capacity. So if I could get the next slide. Here is a diagram that highlights how patients flow through the hospital system. We have heard and seen, and we see in the data that the bottlenecks in this flow. In particular, I want to highlight the bottlenecks in inpatient discharges due to lack of post-acute care placements. This results in patients that stay longer in inpatient beds than they need to. And for behavioral health, there may also be bottlenecks to safe discharge into community-based care from the inpatient setting. Patients staying longer in inpatient beds then results in backup for patients awaiting those beds in the emergency department, which then causes ED boarding for both patients experiencing medical conditions or behavioral health conditions. So over the next several slides, we can move to the next slide. I'm going to show different ways of thinking about our inpatient capacity. On this chart, we see that all categories of inpatient stays have decreased from 2018 to 2023. The blue bars show total inpatient stays for 2018, so the number of inpatient stays, and the orange bars are 2023. The total number of stays have decreased across all of the categories shown. There was a 22% decrease in behavioral health stays, the bars all the way on the left, and a 3% decrease for stays originating in the ED, the two bars on the right. On the next slide, while overall stays went down, overall hospital capacity, that is the average daily bed days to staffed beds, did not decrease. This map shows an increase in occupancy from 2016 to 2023 for most regions in the state. The hospitals in orange, the regions in orange and the regions in red are experiencing occupancy rates of over 80%. You can see that Metro Boston, the South Shore, and New Bedford are in orange and red. Over this time, acute care hospital beds increased slightly by 3%, but the average daily census increased by almost 10%. I also want to note that these numbers do not yet reflect the closures of Kearney and Neshoba, which represent a loss of approximately 129 beds. Bringing the points from the prior two slides together, if we can move to the next slide. How is our occupancy increasing with similar numbers of staff beds and less stays? This chart, there's a lot going on in this chart, and this chart examines the change in stays. So this is the light blue. A change in the average length of stay, that's the dark blue bar, and the change in total bed days, that's the hash orange bar. For all types of inpatient stays except maternity, the length of stay has increased. This increase in average length of stay increases our overall total bed days by 5%, despite a 7% decrease in admissions. As seen all the way to the right, inpatient admissions from the emergency department staying longer were the main driver for an increase in overall bed days. And so looking at this more on the next slide, in our prior post-acute care work, we've shown that the length of stay varies by where the patient is discharged. In this graphic, we restricted to patients admitted from the emergency department because this is where we saw the greatest increase in total bed days. and we examined the increase in average length of stay over time from 2018 to 2024. While we see increases in length of stay regardless of discharge setting, we see the greatest increase for those patients being discharged to a skilled nursing facility. That's the top line in yellow. These patients ended up staying in an inpatient setting 1.4 more days on average in 2024 than in 2018. HPC had previously identified that the lack of post-acute beds, workforce challenges in post-acute care, and prior authorizations as impediments to discharging patients in a timely manner. Knowing that there are these difficulties in discharging patients, on the next slide, we examined inpatient stays that were on the extreme end, those who had extra long lengths of stay. Here we define that as stays over 30 days. The number of bed days for these extra long lengths of stay more than doubled from 3.8% in 2016 to almost 9% in 2023. The increase in these long stays account for half of the growth in bed days since 2016. So half of our growth in bed days is accounted by these patients who are remaining in the hospital for over 30 days. Stays for behavioral health are 4 of the top 10 diagnoses among these extra long stays in acute care hospitals. On the next slide, we then look at time in the ED. Ultimately, these longer lengths of stay in inpatient beds result in longer lengths of stay in the emergency department as people spend time waiting for an inpatient bed. These graphs show boarded visits defined as 12 hours or more in the emergency department by the type of visit. The blue is all ED visits, the orange is non-behavioral health visits, and the yellow is behavioral health visits. In the first 6 months of 2024, 10% of patients who visited the ED spent 12 or more hours there. This has been an increase. There has been an increase in ED boarding for both non-behavioral health visits and behavioral health visits, as you can see on this graph. Almost 39% of patients visiting the ED for behavioral health related problems experienced boarding by 2024. And as several of you are aware, HPC has been tracking behavioral health boarding for several years. With that, on the next slide, we've been tracking behavioral health boarding for several years, and then pursuant to section 145 of chapter 126 of the Acts of 2022, the HPC was tasked with completing a study to the legislature on behavioral health boarding. This report will contain information on the length of stay, type of insurance coverage, and more. Today, I will be sharing our findings on some of the bullet points listed on this slide, with more information coming in the report. Next slide. So some table setting in the next couple slides on what ED boarding is. So emergency department boarding occurs when patients are held in the ED awaiting further treatment or placement into a higher level of care. And this can occur for patients with medical or psychiatric conditions. Behavioral health emergency department boarding may occur for several reasons, such as delayed evaluation, waiting for lab results or other medical clearance, lack of inpatient beds, and delays in finding appropriate care in the community for those who do not need an inpatient level of care. There may also be additional administrative barriers to transferring patients to other settings. And before I present any data, I wanted to emphasize that behavioral health boarding is harmful to the patients and their families, and that it also impacts hospital staff, non-behavioral health patients in the emergency department, and emergency medical services. Next slide. The slide has a lot of text, but we thought it was important to include that there are many stakeholders who care about emergency department boarding and have different ways of defining boarding. Some of this variation is based on the problem the organization or researcher is trying to solve or understand, and sometimes the definition is based on the data they have available. The American College of Emergency Physicians says any patient remaining in the emergency department over 4 hours should be considered boarding, that all patients who enter an ED should be able to have their next level of care determined and moved on within 4 hours. The Massachusetts Hospital Association conducts a weekly point-in-time survey. They conduct this survey Monday morning and count any behavioral health patients in the ED or in a medical surgical bed as opposed to a psychiatric bed as experiencing boarding. The expedited psychiatric inpatient admission policy focuses on patients spending 24 hours or more in the ED awaiting an inpatient bed as boarding. This policy, which I'll talk more about shortly, is really focused on patients who need an inpatient level of care. Finally, most relevant for the work that we'll be talking about today is the definition in Chapter 177 of the Act of 2022, where boarding is defined as 12 hours or more after being assessed, regardless of discharge status. This is the definition we adopted for most of the analyses you will see today and has been the definition used in prior HPC work. I'm saying adapted because we don't have the exact time when a decision has been made regarding treatment for a patient within the ED. We only have access to the total time spent in the emergency department. So with that, I would like to expand a little bit more on the expedited psychiatric inpatient admissions on the next slide. So this is a policy that started in 2018 to facilitate the placement of patients in need of psychiatric hospitalization. There were many different parties involved in the creation of this policy, including providers, carriers, their trade associations, and several state agencies. The policy sets clear steps and responsibilities for escalating cases where patients are experiencing boarding. To the left of this slide, we provided a high-level summary adapted from the Department of Mental Health's website, but there is much more detail in the policy linked at the bottom of the slide for those who want to read the policy in detail. DMH on the next slide tracks referrals to the expedited psychiatric inpatient admission policy. As I mentioned previously, these numbers will not be the same as other ED boarding numbers in this presentation because this policy applies to patients who are determined to need an inpatient level of care and have already spent 24 hours in the ED. As you can see on the line graph, the number of referrals has been declining. As of the most recent report in November, the average time to placement among somebody who had been in the ED for 24 hours and was looking for was in need of an inpatient bed was 2.4 days, and almost half of these patients were enrolled in a Mass Health ACO, MCO, or PCC plan. Almost 10% were commercially insured. So this is one major effort of the state to reduce ED boarding. Other state efforts on the next slide include the launch of the Behavioral Health Helpline in the Community Behavioral Health Centers, which launched in 2023. The goal of the Community Behavioral Health Centers are to get residents the care they need, when and where they need it. These brick and mortar centers are open 24 hours a day and are an alternative to the ED for certain patients. However, some patients still end up going to an emergency department after visiting a community behavioral health center if they need to wait for placement for an inpatient level of care or if they need additional medical clearance. And then another effort is the Division of Insurance has issued a bulletin emphasizing the importance of commercial insurers and hospital providers participating in the EPIA process. DOI is one of the partners in the EPIA process, and they have issued this bulletin that emphasizes that commercial insurers and hospital providers work together to arrange payments for services that higher acuity patients, often patients that are harder to place in inpatient settings, receive payment for things such as one-to-one staff to patient ratios. And with that background, we are going to move into some of our analyses. For the following slides, we are using several different data sets to better understand behavioral health emergency department boarding in the Commonwealth. First, we are using our the Center for Health Information and Analyses acute care hospital case mix databases, which include all inpatient stays, observation stays, and emergency department visits in the state. Inpatient and observation data sets also include information on the original ED visit if a person started their stay by coming into the emergency department. We then link the hospital databases, which contain information on the length of time spent in the ED, to our all payer claims database, so that we can estimate spending and follow-up care. This is the second time we have used this linking in our work to better understand spending and follow-up care. The first was our severe maternal morbidity work, which we presented this past, or almost a year ago now. Next slide. The HPC examined the overall trend in behavioral health ED boarding from January 2020 to May 2024. And as noted previously, we're defining ED boarding here as 12 or more hours in the ED. During this time period, we observed an increase in boarding for mental health, that's the top line in orange, substance use disorder, which is the bottom line in yellow, although a little not more flat. And then in the middle, we have the behavioral health line, which includes both mental health and substance use disorders in blue. By May 2024, we observed that nearly half of mental health related ED visits, the top line in orange, spent 12 or more hours in the ED. On the next slide, the study has asked the HPC to understand who in the Commonwealth ends up experiencing ED boarding. And so here we're looking at the demographics of residents who have experienced boarding. Residents who boarded during a visit were more often children, were more often covered by Mass Health, lived in lower income communities, and were Asian, Black, Hispanic, or a race other than white. However, compared to the overall population, however, this is actually similar to the demographics of patients who show up to the emergency department seeking behavioral health care, meaning that children, persons on Mass Health, etc., are more likely to show up in the ED in the first place for their behavioral health needs. On the next slide, among patients who show up to the ED and wait for 12 or more hours, about a third end up going home. That's in the dark blue. And I want to note, although I'm showing 2023 data here, it has remained about a third of patient for all the years we examined. 30% are transferred to another facility in the orange, and 22% are admitted to inpatient at the same hospital. 15% of patients were admitted to observation and then discharged from observation. That's in the light blue. We heard from some stakeholders that they would move patients into observation when it was clear that a patient that needed an inpatient level of care would not have had a bed for 24 hours. But we also have heard that moving patients to observation could allow for a higher reimbursement. On the next slide.
Laura, one question on that. The 1/3 of patients that are discharged to home, is that viewed to be the appropriate discharge, or were they awaiting an admission, didn't get one, and it's sort of a, we should consider that a quality issue?
That's a great question. So in our data, we are not able to assess, the appropriate care pathway. But what we have heard from stakeholders is that and professionals in this field is that to the extent possible, they want to get people to home if home is a safe place for them. So there has been an expansion of services services and treatments for people so that they can go home. And sometimes during the course of a stay, people can actually change what their disposition is or where they should be going during the course of the stay. So maybe initially somebody was determined to need an inpatient level of care, but 24 hours later, things have changed. They have medications, they have a treatment plan. So we cannot assess it. We're making the assumption that they're being discharged to the right level of care. That's what we see in the data, but we're not able to make that assessment.
If I may ask, how many of those are being discharged like against medical advice, or are they left on their own?
I can get the actual percentage for you after this meeting, but it was pretty small.
But Laura, the data does include like an AMA flag if they left against medical advice.
Yes, there is an against medical advice flag that we looked at, because that was one of the things that we were wondering if, people who if we were seeing, some people might have be leaving against medical advice, and because they're waiting in the ED so long for treatment, and they want to leave, but that it's still a relatively small percentage. It is a little bit higher for people coming in with substance use disorder.
That's true.
And I don't know if that's what you were trying to get at. It is a little bit higher for that, but overall it is a really small percentage, and we can get that for you.
And I think the substance use is incredibly important. I don't think that anybody with substance use disorder can wait that length of time without having some treatment done, medication treatment. And that's our concern, is that most of them leave during that time.
Great questions. The next two slides look more at depth in patients who are admitted to an acute care hospital. So we were interested in evaluating how long patients who were ultimately admitted spent in the ED, whether 24 hours or less. That's the dark blue. We have 24 to 60 hours in the orange, and 60 hours or more in the yellow. For adults who were ultimately admitted to an inpatient psychiatric bed at an acute care hospital, we saw that more than half spent more than 24 hours in the ED in 2022. However, that proportion has declined more recently, where approximately 40% spent that long in the ED for the first 6 months of 2024. But when we look at kids, so on the next slide, we examine how long children spent in the ED waiting for admission to a psychiatric bed. We observed a different trend, where the proportion of children staying in the emergency department for more than 24 hours, again, that's the orange and the yellow combined, has increased from 2020 to 47% in the first half of 2024. So on the next slide, we were also tasked with examining payments and spending related to ED boarding. But before I talk about our spending, I wanted to talk a little bit about inpatient payments. Unlike most medical stays that pay on a per stay or per diagnosis related group basis, MassHealth and several commercial payers pay on a per diem basis starting on the day of the ED visit for patients who end up admitted. Medicare pays per diem for stays in inpatient psychiatric facilities and per stay for stays in acute care hospitals. I also want to say that there have been several policy changes that take place after the data we had available for this presentation. As of January 2023, MassHealth Managed Care can now pay hospitals directly for crisis evaluations instead of requiring patients to be first evaluated by MassHealth emergency service providers or mobile crisis teams. In some cases, these teams may have needed to travel to the hospital ED. So this policy change may result in a decrease in time spent in the ED. This payment is in addition to the standard ED visit payment. In 2023, the Division of Insurance issued a bulletin for commercial carriers stating that they reimburse acute care hospitals for ongoing monitoring and stabilization at a rate at least equivalent to that of Mass Health for these crisis stabilization services. Mass Health has also implemented additional payments for harder to place patients and for weekend placements. We have heard from several stakeholders that weekend placements are very challenging. When we examine differences in payments for those who boarded and those who did not experience boarding on the next slide, we did find some differences. Among patients who are discharged from the emergency department, both commercial and Mass Health paid more for patients that boarded compared to patients who did not board. 22% more for commercial and 33% more for Mass Health. And those are the smaller bars that say discharged from the ED. For patients admitted to inpatient, we found that commercial payments had slightly higher spending if they had experienced boarding than those who did not board. For Mass Health inpatient, we saw that there was actually a decrease in spending among those who were admitted to inpatient and experienced boarding compared to those who did not. For follow-up care, on the next slide, we evaluated the proportion of patients who incurred at least one medical claim for any service within 7 days of their discharge. We observed that regardless of boarding status or payer, patients who were discharged from the ED were more likely to receive additional services within 7 days compared to those who had an inpatient stay. So on this graph, we have, again, the orange is commercial and the blue is Mass Health. And we have discharge from the ED, boarded and not boarded, not boarded and boarded, admitted to inpatient, not boarded and boarded. And we saw that patients who were discharged from the ED were more likely to receive additional services within 7 days compared to those who had an inpatient stay. And while our analyses are not identical to the quality metrics that CHIA tracks in their quality of care in the Commonwealth report, we do note on the sidebar that these rates of follow-up care are roughly consistent with what CHIA has observed in their own analyses of follow-up care following ED visits for mental health concerns. And on the next and final slide, as I mentioned at the beginning, this is just some of the findings and information that will be included in our full report. The report will include information on behavioral health boarding in other states and state policies, more information from our stakeholder meetings and policy recommendations. We also have other legislatively mandated studies that will continue to help us understand behavioral health related boarding in the Commonwealth. We have a study to evaluate the behavioral health access line and crisis intervention, as well as a pediatric behavioral health planning report. As part of the planning report, we are tasked with reporting on the newly launched behavioral health treatment and referral platform. This platform was actually launched yesterday, so the timing of this presentation is fortuitous and aims to facilitate information sharing. This platform aims to facilitate information sharing and bed availability to reduce or eliminate ED boarding. Overall, we see ED boarding, behavioral health ED boarding, those spending over 12 hours or more in the ED awaiting discharge to home or to an inpatient bed as continuing to increase into 2024. This work and report will highlight what we know from the data and what we learned from stakeholders. While the state and other stakeholders have been putting policies and programs into place to decrease ED boarding, such as the referral platform I just mentioned, ultimately this is a multifactorial problem. We know there are challenges discharging patients from inpatient beds into post-acute care and community settings. We have been charged with started a behavioral health workforce center at the HPC because there's a need to understand the behavioral health workforce. And we know from survey data that there is still a very high need for behavioral health services and trouble accessing care or challenges accessing care for behavioral health services. Finally, HPC will continue to monitor and research ongoing hospital capacity concerns. And I want to thank other members of this research team for contributing to this work. Leiden, Katya, Dhruv, and Diana, thank you for your work, and thank you, commissioners, for listening.
Thank you so much. Excellent report. Commissioner McGregor?
Thanks so much, Laura, for the presentation. It was very informative and eye-opening and concerning in a number of ways as well. I have a question around the inpatient stays that you showed. The chart, the sort of side-by-side costs for commercially insured patients versus mass health patients. Yes, it was the one before that with the
One
dollar
before,
amount.
yeah.
Right. So here I'm just concerned. Can you clarify, are the so you said mass health patients are paid per diem, right? It's a per diem rate that mass health pays for inpatient stays. Is that right?
So at this point in time, the majority of commercial payers and mass health pay per diem, yes.
Pay per diem. Okay. Did you see any substantial differences in, say, length of stay across payer type here? Was that something that you were able to look at with this data?
You know, we did look at that, and I don't want to get that information wrong by payer type. I know that length of stay varied a little by whether or not you were in an acute setting versus a freestanding psychiatric hospital. But I can get those numbers for you. I know that we did look at the data many ways, and we had to cut it down for this presentation. And I'm sorry, I don't have it at the tip of my fingers right now.
No, that's okay, because really I'm just wondering, so these dollar amounts are for the entire episode of care by the patient, sort of regardless of the number of days. So we don't have,
Right.
Okay, right. I'd be curious to know whether we saw big differences here in terms of whether or not commercial patients are staying shorter stays versus mass health or vice versa. I would be curious to know that. The other question I had was around one of your earlier slides where you mentioned the tremendous impact that the closures of Neshoba and Kearney will have on the supply of behavioral health beds. And I think you said it was around 129 or so. And I was wondering if you could give us a sense of what percentage of total behavioral health beds that would account for.
So there, the 129 was including medical, surgical, and behavioral health beds, but I believe Neshoba did have, in particular, had a large number of behavioral health beds. And I can definitely look into that number.
But Laura, those were all hospital beds.
Those were all hospital beds.
Okay. But across the state of Massachusetts, across the Commonwealth, would you say, you know what? I think I could find these numbers. I feel like I'm asking very specific questions here.
I'm happy to get you those numbers. I just don't have them right here, so I don't want to say the wrong number.
Okay, sure. Well, thanks so much. I'll go ahead and reach out to you on email.
Perfect, thank you. Commissioner Coughlin?
Thank you so much. So I do have some questions, like just a couple of thoughts maybe. You know, that I know that we have heard on the ground, you know, emergency department staff, they haven't seen the behavioral health roadmap that like you were kind of like referring to play out as it should. And I was just wondering if you had been talking to ED staff to see how the roadmap and the community behavioral health centers are working in practice, because we have heard some concerns. So that's my first thought. And then my second thought is, you know, I think we need to be cognizant of the fact that potentially the proposed 50% reduction in DMH case managers from 340 DMH case managers to 170 could affect ED boarding moving forward. And I know that we also, just as an aside, we lost a number of psychiatric beds when Connie closed. Those haven't been, and right now we have a pause on the behavioral health beds down at Pecasset Mental Health Center, but that is a pause. That isn't a stop of the closure. So that's a pause. So those are just a few of my thoughts. I think we just need to be cognizant of some of the concerns that we are hearing from emergency room staff, that calls are still going unanswered. And that, you know, there could be the potential, given the closures, and the layoff of case managers who oftentimes, you know, in lieu of PCPs, are the first line for behavioral health patients to avoid hospitalizations or moving further into behavioral health crisis. So
on your first point about emergency departments maybe not knowing about the roadmap and if I've heard anything, we have talked to a couple different stakeholders in the emergency department space, and we have heard, and I don't know if this is a new thing or not, but the need for medical clearance, and so some patients are being sent to the EG to get medical clearance, and then they're in the EG, and whether or not the emergency department stakeholders express some, you know, do all these patients actually need to come to the ED for medical clearance was a question they had. So, and then the other thing that we heard regarding community behavioral health centers is that if a patient goes there and they are determined to need an inpatient level of care, but a bed is not going to be available for that particular patient for a couple of days, then that setting might not be the community behavioral health center setting, or that community behavioral health center in particular might not be the right setting of care. So I think that we have heard some people say they have really strong, some EGs have really strong relationships with community behavioral health centers. And I've also heard that one community behavioral health center, they have adopted, they're all in different places growing and what they're able to handle.
Would you be able to differentiate between the types of behavioral health patients that we're seeing in the EDs that are having difficulty moving to an inpatient setting regarding the reasons, what those barriers are for community behavioral health centers? Because my guess would be that they have severe challenging behaviors that may not be able to be addressed in a community behavioral health center. And there is a need for more beds, actually, related to more intensive stabilization units within the Commonwealth to address those patients. So they're like outliers, but they're out there. They are definitely out there. And in all actuality, I think just anecdotally on my end, we have seen an increase in the number of those types of patients. In all honesty, I think a lot of times it stems from the inability to receive early intervention in when they're children or adolescents. And so then they end up kind of growing up within the system, and a lot of their responses to trauma and the challenges of their illness are learned negative responses. And so then they become, unfortunately and horribly, because of a lack of appropriate care, patients who find themselves, turned away from other behavioral health settings because they can't handle the challenges that they present.
Useful observation. I'm now going to move to Commissioner Cohen, and I'm going to ask that, despite the fact there's a lot more to talk about, that we make this our last question, just in the interest of time.
Thanks, Deb. I'll be very brief. I think, first of all, Laura, thank you. This is great, and look forward to the full report. This is a problem that A, has been around a long time in the Commonwealth, and two, for which there is really, I think we have to look at both the sort of front door and the back door, and really what's the whole continuum of community behavioral health services that are necessary to support individuals and families. I think we really have to go upstream here in terms of starting with, what does integrated primary care and behavioral health look like so that people are adequately screened and there's good treatment available early on, the crisis stabilization that exists both at the community behavioral health centers and in community settings. One problem that I'm hearing about community behavioral health is that ambulances won't take patients there. They'll only take them to the ER, which I think is something relative to a DPH requirement. But I think this is one where, we have to think about why people end up in the ER first. And in many cases, I think the sort of adding to the capacity of the community system is where we really need to put emphasis. There's certainly a need for more, inpatient and aftercare beds, but I think it would be wrong just to focus on the back door and not also look at the front door.
Thank you.
Great discussion. Thank you so much, Laura, for a very useful report, and to all the commissioners for digging deeper and illuminating this more with our back and forth. Much appreciated. We're now going to move to the next agenda item, which is the HPC's preliminary report on the cost and market impact review for the proposed clinical affiliation between Dana-Farber Cancer Institute and the entities, hospital and physician, at Beth Israel Deaconess. Let me turn it over to our Executive Director, David Seltz, to introduce our topic.
Thank you, Chair DeVoe. And just to put a little bit of bow on the previous discussion, Commissioners, we look forward to engaging with you as we're putting that final report together. As you said, Commissioner Cohen, this isn't a new issue that has faced the Commonwealth. And so I think we want to be, as we think about policy recommendations, how can we really help advance some interventions that will really make a difference, knowing that there's been a lot of work in this area. And more broadly to members of the public who are watching online, we know that many organizations and people have been impacted by this phenomenon and have been working on this phenomenon. And I will volunteer, Laura would be very willing and open to continuing to hear from different people. So please reach out to us as we continue this work. Finally, I'll just say, Commissioner Cohen, the issue of integrating behavioral health into primary care and strengthening that setting is something that I hope will be a part of the primary care task force that is going to be launched imminently. So moving into this agenda item, it's been many years since, a few years since the last time that we have issued a cost and market impact report. So I do just want to provide some foundation and level setting for commissioners before turning it over to Sasha Hayes-Rusnov, who is going to be leading you through our findings in this preliminary report. The HPC's process for reviewing significant changes to our healthcare market is really one of the most important and impactful responsibilities that we have. This work is critical for enhancing the public transparency of these changes and the potential impacts on affordability, on access, equity, the quality of patient care, the healthcare workforce, and importantly, the Commonwealth's ability to meet the healthcare cost growth benchmark. We received initial notice of this proposed new clinical affiliation between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and Harvard Medical Faculty Physicians in late 2023. And then after initial review, we determined that the affiliation was likely to have a significant impact on healthcare costs and market functioning, and exercise the HPC's authority to conduct a full cost and market impact review. This preliminary cost and market impact review report that you'll hear from today reflects many months of work and examination by the HPC team with consultation with our contracted economists, actuaries, accountants, and care delivery experts. We conduct this work by evaluating confidential information provided by the transaction parties and other market participants, as well as all available data on healthcare costs, prices, quality, and access. And for this transaction, which represents a major realignment of cancer care in Massachusetts, we specifically investigated the unique dynamics and aspects of oncology care and the current clinical relationships that the parties have, and how the new proposed partnerships in the future will change cancer care for residents of the Commonwealth. I would note that while the HPC currently lacks the authority to deny or approve a proposal or impose conditions, through this work, we really aim to influence market behavior to further our statewide goals, and specific to any transaction to minimize the potential negative impacts and maximize the potential positive impacts. So after issuance of this preliminary CMIR, Dana-Farber and Beth Israel will have the opportunity to respond and hopefully make further commitments and assurances to address concerns raised in this report and to achieve this goal of minimizing negative impacts and maximizing positive impacts. But reflecting the importance of the HPC's review, the proposal cannot move forward until the HPC completes its final cost and market impact report, which we expect to release in April. Finally, before I turn it over to Sasha, I want to acknowledge the engagement and collaboration of Dana-Farber and Beth Israel throughout this process. We are grateful to them and their teams for their open and professional cooperation, and really for being willing to be able to meet with us throughout this process and answer our questions and provide any additional information as we requested. And I also want to recognize other market participants who provided information to us on this review, and of course, to you commissioners for your leadership and guidance and expert counsel throughout this really important review. So with that as an introduction, I think let's dive right into our review, our findings. Commissioners, there's a fair amount of material here. We do believe it's important to be able to present the whole arc of our review, but nonetheless, absolutely encourage you to ask questions and stop us along the way as we move through these findings. And with that, Sasha, I'm happy to turn it over to you.
Great. Thank you, David. Thank you, commissioners. As David said, it has been 5 years since our last CMIR. So just to review, this presentation will largely mirror the scope of the report that we'll be releasing, first covering some background material on the parties and what is being proposed in their proposed transaction. Then our substantive analysis, which falls into 3 conceptual buckets of assessment of the cost and market impact of the transaction, potential impacts on quality of care, and potential impacts on accessibility and equitable access to services. And then we'll wrap it up. So on the next slide, I'll try to hit only the highlights here. Dana-Farber Cancer Institute is the only dedicated cancer hospital in the Commonwealth. It is unique both in Massachusetts and nationwide, is our understanding, in focusing solely on medical oncology care and relying on other clinical partners for other aspects of the oncology care continuum. It provides most of its care on an outpatient basis at its hospital licensed satellites and its main campus site. And for inpatient care since 1997, it's had a collaboration with Brigham and Women's Hospital, under which it leases 30 beds within the Brigham and Women's Hospital site, and its medical oncologists cover and staff medical oncology care within Brigham and Women's. Dana-Farber also has staffing relationships with some other hospitals, and clinical affiliations throughout the Commonwealth and New England. Next slide, please. And you can see those sites and some of Dana-Farber's partnerships on this map. But we won't linger. Next slide, please. BIDMC is the anchor AMC for Beth Israel Lahey Health, one of the anchor AMCs for Beth Israel Lahey Health, and the third largest hospital in Massachusetts. Its specialty services are all staffed by HMFP, which is an independent physician organization affiliated with BILH. And BIDMC and HMFP currently provide the full scope of adult cancer care services. Next slide, please. Next. So, as David said, the proposed affiliation would be a significant realignment of these major cancer care providers. The affiliation between Dana-Farber and Brigham runs until at least 2028, at which point, when it expires, Dana-Farber is proposing to shift its affiliation to BIDMC and HMFP. The parties would collaborate for DFCI to construct and operate a new cancer hospital on the current site of Joslin Diabetes Center, which is part of BILH. And DFCI would become the preferred provider for medical oncology for BIDMC and Longwood. HMFP medical oncologists would become DFCI employees, and BIDMC would effectively discontinue independently providing medical oncology services. BIDMC and HMFP would become DFCI's preferred providers for surgical oncology care and for certain other services that might be needed by DFCI patients at the new hospital. The parties would coordinate their provision of pathology, labs, diagnostic radiology, and other ancillary services for their cancer patients, and they would form a joint venture and a joint physician organization to provide radiation oncology services. DFCI would join BILH's medical record system. And unlike in some other transactions we reviewed, the parties would remain corporately independent, and they don't currently anticipate jointly contracting with payers. And so, a differentiation from some of the other transactions we've seen. The next slide summarizes the details of the clinical affiliation, as well as providing some major features of the proposed new hospital. 300 inpatient beds, including the 30 that would move over from Dana-Farber's current license, 20 observation beds, and expanded diagnostic imaging units, and 3 new linear accelerator units. Next slide, please. And here we're reviewing again how conceptually we would expect that this would impact where patients receive care. BIDMC discontinues medical oncology, and HMFP medical oncologists move to DFCI. So we would expect that most of BIDMC's medical oncology service would transition to DFCI as the new primary clinical partner. For patients who've traditionally gotten medical oncology care at Brigham, we expect that many of them may come to get care at the new DFCI facility. I'll note that the actual existing patients at the time that the transition happens are going to have relationships with their medical oncologists and may well be likely to follow those folks to DFCI. But we're thinking not only about those actual patients who will exist at that time, but also the people who won't have had their cancer diagnosis now, but are going to need inpatient care in the future, and what their options and choices are going to look like as well. MGB has obviously stated an intention to continue providing cancer care at Brigham under its new unified academic cancer center. So, we believe that some care may continue to be provided at Brigham if those plans, continue to follow through. For surgical oncology care, Dana-Farber expects to be, again, referring patients to BIDMC rather than to Brigham. So we expect some shift of surgical oncology care to BIDMC, again, subject to the, whatever success MGB has in retaining its patients, as it's stated it intends to do. And we also expect radiation oncology services, which are largely outpatient, to go to the party's new JV, both, from the party's existing services as well as probably some of the care that's provided by Brigham now. Next slide, please. The parties have given a variety of reasons for the proposed affiliation will be beneficial for the Commonwealth, including increasing access to cancer care, especially high acuity inpatient care, a shift of patients from higher priced providers, particularly MGB, to the parties as relatively lower priced providers of these services, and improvements in quality of care, building on the parties' expertise in this space to date, as well as the benefits of having this new custom-built cancer hospital. Next slide, please. Before we move on to more substance, I'll take a moment on the concurrent review process going on at the Department of Public Health. To build its new hospital, Dana-Farber requires a determination of need, or DON, from the Department of Public Health. DPH staff review DON applications under a specific set of factors laid out in their regulations that include demonstrated need by the applicant's patient panel, public health value, and accordance with the Commonwealth's cost containment goals. DFCI filed its DON application concurrently with its MCNs to us. The DON team required an independent cost analysis, an evaluation by a third-party consultant paid for by the applicant. That ICA was accepted in January, and DON staff published a staff report last week on the project, recommending the project be approved with a set of conditions. The Public Health Council is the body that makes a final vote on those recommendations, and they can vote to approve the recommendations as provided in the staff report or amend them. And I'll note that the HPC is a party of record to all determination of need applications, and because HPC may comment and we're in the window in which comment is open, one of the things that we're proposing is to provide a copy of the preliminary report on this transaction to the DON program for consideration, as is whatever is consideration is due in their review. And we currently understand that the plan is for PHC to take this up at their March meeting. If they do, I'll note that the DON regulations also say that any DON can't go into effect until the conclusion of our process, and the Public Health Council may reopen review if they see materials in our final report that influence their assessment of the DON factors. And you'll recall that this happened in our last CMIR with the formation of Beth Israel Lahey Health. So this is not unusual and is a useful element in the regulations where the timelines, which are largely set by statute, don't always sync up. So with that, we'll move on to the findings and can go on to the next slide. In the cost and market space, we looked at current market shares and prices, and then use those data to model out potential shifts in care and impacts on spending at current prices, and then assess potential for future price changes and the market impacts of those shifts. So on the next slide, you can just see the parties draw patients from across the Commonwealth, and Dana-Farber also serves a significant proportion of out-of-state patients. But these primary service areas you see on the map here, which are overlapping, show that they draw 75% of their inpatients from Eastern and Central Massachusetts. So just to give you a scope of the primary areas for discharges for our residents. Next slide, please. We looked at market shares for inpatient medical and surgical oncology. MGB has the largest share of inpatient services for inpatient care for these services, and obviously with the caveat that Dana-Farber manages patients at Brigham and Women's for medical oncology. And BILH is the second largest share, with BIDMC being the third largest individual hospital provider of these services. Next slide, please. As I said earlier, DFCI provides most of its care on an outpatient basis and is the largest provider of medical oncology outpatient services in the state, as represented here by infusion administration and oncologic drugs. Next slide. Looking at price, We estimated relative prices for inpatient oncology using claims data, adjusting for patient acuity. Dana-Farber and BIDMC, as you see here, their current commercial inpatient prices are lower than many other major providers of oncology care in the Commonwealth, higher than some other providers of oncology care in the Commonwealth. Next slide, please. For outpatient care, we examine prices for select service lines that are particularly relevant to oncology care. We found a particular note that Dana-Farber's prices tend to be substantially higher than many other hospitals for outpatient care, while BIDMC's prices tend to be more moderate. And I'll note that the price differentials that I've shown you in the last two slides here reflect the relativities amongst hospitals, averaging across providers of oncology care, taking average service mix and average payer mix. As we move into spending impacts on the next few slides, we've further adjusted those for the payer mix and the service mix or acuity of patients that we expect to shift to get not only not only taking the average prices as you're seeing them, but the actual adjustments for the patients that we would expect to shift under the various scenarios that we ran out. So on the next slide, we take a look at inpatient care. A summary slide here on the baseline. We'll skip past it. Next slide, please. For inpatient care, we modeled a few scenarios for how DFCI might fill its new beds and where those patients might otherwise have received care. What we're calling here the party scenario or party model assumes that DFCI would first take med-onc patients from BIDMC and from Brigham, and then would fill remaining capacity with patients from other hospitals based on an econometric patient choice model. The patient choice model here that we're using for these analyses is the same one we used in every past CMIR. Obviously, it's been updated over the years. In this case, it's specific to oncology patients, but it essentially predicts where patients would likely go for care based on factors like diagnosis and drive times to various hospitals and other factors that influence patient choice. So since there's uncertainty about how much oncology care Brigham might retain, our preferred model is not the party scenario model, but the model-driven scenario here, which assumes that Dana-Farber would still get all of BIDMC's volume because, again, BIDMC is discontinuing its medical oncology service in favor of Dana-Farber, but that the rest of Dana-Farber's capacity would be filled with patients based on that patient choice model. And the choice model still pulls a substantial volume from Brigham and from MGH because those hospitals have patients that are most similar to Dana-Farber's high acuity set of patients. Under both models, based on the current price differences between Dana-Farber and other hospitals for commercial payers, filling Dana-Farber's beds would reduce commercial spending by $18.5 to $23 million a year. We have focused, I'll say, on the spending impact of patients choosing Dana-Farber over other hospitals to the extent that patients go to Dana-Farber who wouldn't otherwise have used hospital care. Obviously, that would just increase spending. So we've focused on the price differentials as opposed to the cost of adding net new patients to the system. Next slide, please. As Dana-Farber fills its beds, we expect that other hospitals that would have served those patients are going to try to backfill those beds. You can make a lot of different assumptions about the extent to which hospitals would be more or less likely to succeed in that effort. We've modeled scenarios here for spending impacts if BIDMC were to backfill capacity that would go to Dana-Farber, and if Brigham would backfill capacity that we've modeled as going to Dana-Farber. Both BIDMC and Brigham are going to be trying to backfill with cancer care, BIDMC with surgical oncology care that it hopes will be associated with Dana-Farber patients, Brigham with medical oncology care that it hopes to bring in under the MGB Cancer Center banner. And we've also modeled for each, if they aren't successful in drawing in cancer care, what happens if they fill those beds with non-oncology general acute care patients. Under both scenarios, inpatient shifting to BIDMC would likely reduce annual commercial spending. Estimates based on the patient choice models give a range of $3.5 to $5.3 million. If BIDMC backfilled solely with Brigham surgical oncology inpatients, that savings would be as much as $7.4 million. We think that that's sort of an upper bound and less likely, given that DFCI, our models suggest, is going to be serving patients other than just Brigham patients, and the surgical oncology volume is going to be associated with those patients. For Brigham, backfill would generally increase annual commercial spending as it backfills with patients from hospitals that are generally lower priced. Next slide, please. For hospital outpatient care, data aren't sufficiently robust to do patient choice modeling in the same way that we do with inpatient care, so we've quantified impacts as best we can based on the parties' transaction plans. With BIDMC discontinuing medical oncology care and HMFP medical oncologists transferring to DFCI, infusion and oncology drugs, the expectation is, will be provided at Dana-Farber and presumably at Dana-Farber prices. For those same set of drugs and same quantity as is currently provided at BIDMC, moving those to Dana-Farber's higher prices would increase commercial spending by $26.5 million for the drugs and another $1.5 million for the infusion component of the service. Higher prices for evaluation and management visits with those HMFP oncologists would be an additional increase of $3.6 million. And then we also modeled some shifts in radiation oncology services as it transitions to the party's JV, assuming that that JV gets prices similar to Dana-Farber's prices for radiation oncology. That's additional spending increases. We also modeled some potential shifts from Brigham to Dana-Farber and BIDMC, and you can see that shifts to Dana-Farber would generally increase spending, although shifts of outpatient surgical services to BIDMC would tend to reduce commercial spending. Next slide, please. We looked separately at Medicare spending. Most hospitals, as you know, get similar base rate payments from Medicare, but Dana-Farber is different. Being a dedicated cancer hospital, CMS reimburses Dana-Farber in part based on its costs. At current Medicare rates, Medicare inpatients shifting to Dana-Farber would tend to reduce spending on the range of $5.7 to $9.1 million. Those are based on current reimbursement rates as we calculate them. Dana-Farber's reimbursements are based on cost per patient for inpatient care. And so I think there's some uncertainty about whether that rate differential would continue to hold based on Dana-Farber's cost per patient in the new facility that they're planning to build. Outpatient care to Dana-Farber may increase Medicare spending. Dana-Farber gets supplemental payments from Medicare, as do all cancer hospitals that target a specific revenue to cost ratio. CMS estimates that Dana-Farber will be getting about 46% higher reimbursement than hospitals paid under the standard payment system. We can't fully adjust for service mix as readily for these outpatient services. A rough estimate, though, on repricing BIDMC's outpatient oncology Medicare spend to Dana-Farber's prices at that rate increase would be about $17 million additional Medicare spending per year. But again, that number isn't as carefully adjusted as some of the others that I've presented. Next slide, please. Everything that we've discussed so far, savings and increases, is all based on current price differentials. DFCI is going to gain market share in this transaction, which would tend to improve its ability to negotiate higher rates with commercial payers. But it's also going to have to compete to fill those new beds. And having DFCI as a larger competitor could theoretically constrain price increases for other competitors in the market. But we'll note that Dana-Farber's inpatient prices could increase substantially while still remaining a lower priced option than the MGB-AMCs that are its largest other provider competitors. Shifts in care may also impact other oncology care providers, adding all of the inpatient shifts to Dana-Farber and the backfill at BIDMC and Brigham hospitals, hospitals other than the party hospitals and Brigham and MGH, we would lose, we estimate, $60 to $64 million in commercial inpatient revenue per year. They may also face higher labor costs for oncology specialized staff as Dana-Farber staffs out its new hospital. And to the extent that those factors impact oncology care capacity at other providers, that would further concentrate the market and increase the likelihood of higher prices in future, as well as potentially having access impacts. And commitments from the parties may help to address some of the concerns raised in these findings. We can go to the next slide. I would normally pause for questions, but I know we're short on time. And so if you have any, put your hand up. I'll roll on to the next slide instead. And next slide again. In examining quality of care, we looked at the parties' current initiatives, reviewed performance on available oncology-specific quality measures, and assessed the parties' plans related to this transaction that involve improvement of quality. Next slide. BIDMC and DFCI are both high-quality institutions recognized for their cancer care programs. They both run numerous programs designed to promote cancer care quality for their patients. I'm not going to just read through all of these, but they're obviously very well-regarded institutions. Next slide. There are relatively few publicly reported measures specific to oncology care. The HPC worked with clinical consultants to examine the ones that were available, and generally we don't identify concerns certainly about party performance on these measures. I'll say Dana-Farber was the only hospital in the Commonwealth with statistically better survival rates for its allogeneic stem cell transplant patients. And I'll note that there's national research showing that PPS-exempt cancer hospitals outperform other hospitals on oncology outcomes at the cohort level. But we didn't see that those studies necessarily allowed us to make additional assumptions about DFCI's quality relative to other high-volume academic cancer programs in the Commonwealth. Next slide, please. With regard to impacts on quality from this transaction, the parties have stated that they intend to expand some of their current care delivery initiatives and to collaborate to bring forth new ones. Developing those sort of programs obviously has the potential to improve quality, but the parties' plans, probably understandably, aren't yet at the stage where we can look at them in detail and assess the likelihood of any specific outcomes. Dana-Farber has also identified a number of ways in which its new hospital would be designed and operated to promote high-quality care. All of those features look likely to promote high-quality care. And ongoing reporting of the sort contemplated in the DON conditions as proposed in the staff report would allow assessment of what the impact on quality of care is over time to the extent that that can be measured. Next slide, please. One area that we wanted to call attention to is the potential for short-term disruptions in care coordination. Patients, if the transaction goes forward as planned, patients are going to be adapting to new care teams. Clinical teams are going to be disassembled and reconfigured with a lot of new relationships having to be built. I think it is fair to say the parties are aware of the importance of planning to avoid disruption. And we're recommending that there should be ongoing reporting about planning and implementation of those plans to avoid disruption of care as the transaction goes forward. Next slide. This slide just summarizes the prior points. So we'll move on to the next after this. In the access and equity assessment, we looked at inpatient utilization trends and the accessibility of inpatient oncology care. We looked at payer mix and demographics of oncology patients and the party's role in serving traditionally underserved populations. And we looked at the party's proposed access and equity plans, both current plans and their plans for expanding those efforts. So next slide, starting off with a question. So statewide inpatient oncology utilization has increased slightly in recent years, driven by utilization by older adults. As we previously covered, Dana-Farber has asserted that increased capacity is needed, that it's needed due to an aging population, increased cancer incidence, novel therapies and higher acuity patients that require longer inpatient stays, and by current capacity constraints for inpatient care. We took a look at these factors, and our assessment is that we can't say with certainty that the expansion proposed by Dana-Farber is either necessary or that it is sufficient to ensure future access to inpatient care. So I'll walk through our assessments of what we see in looking at the projections of future bed need and utilization based on demographic trends. I'll walk through some of the other factors that are likely to influence current and future inpatient oncology utilization and the uncertainty around those factors, and also the availability of data on current inpatient oncology capacity. Next slide, please. So, as I mentioned, in Massachusetts, inpatient care has been driven by increasing discharges for older adults, with decreasing discharges for younger cohorts. And on balance, that results in an increase of only about 1.6% over the years that you're seeing here. Total bed days, however, has increased more substantially. Next slide, please. So DFCI and the ICA consultant projected future bed need increasing by between 18 and 27% or so. And the ICA projection was based on population projections and recent trends in utilization for oncology care. We ran a similar model, assuming that demographics is the only driver of utilization. And we got about a 10 to 16% increase in inpatient utilization based on those terms. But our biggest takeaway from this exercise was that the sensitivity of these models to how you choose to build them and choosing a different year for baseline utilization, we found just between 2019 and 2023 utilization hiked the projected need for new beds by more than a third. And that suggests to us that demographic modeling alone may wildly over or underestimate future utilization. And we've talked in prior reviews about how it has often been an overestimation when we've looked at the historical course of general acute inpatient care. On the next slide, one particular confounding factor is increasing length of stay. And I'm glad that Laura had her presentation immediately prior to this, because I can go very light on my explanation here. We, with the help from our friends in Research and Cost Trends, we looked at the question of, do we see the same sort of impact of post-acute care capacity crunch for oncology patients? And the answer is yes. The length of stay increases that we're seeing are driven by patients being discharged to institutional post-acute care and home health, as opposed to folks who are getting routine discharges, which again suggests that workforce and capacity issues in post-acute care are one of the drivers of increased inpatient bed days for oncology. And utilization models that build on trends from these years are going to build in that effect. Next slide, please. With regard to incidence, we took a look at data from the Mass Cancer Registry, which tracks all new reported cases of cancer in the Commonwealth. The count of new cases you see in blue here has increased over time, driven by an aging population. But age-adjusted incidence, the Mass Cancer Registry finds, has actually declined between 2000 and 2020. And we also reviewed incidents compared to utilization trends and found that the effects aren't linear. Not every cancer patient, not every cancer diagnosis is going to result in an inpatient stay or the same amount of inpatient stay. And so whatever incidence trends are happening, that doesn't necessarily translate to a linear impact on inpatient utilization. Next slide, please. With regard to changes in care techniques and novel treatments, it's true that there have been some cutting-edge therapies like CAR-T and bispecifics that have required longer inpatient stays and have frankly had a huge impact on the ability for the survivability of certain types of cancers. But novel therapies haven't only resulted in more inpatient care. Over the last 2 decades, we've seen more care for oncology delivered outpatient than ever before. And Dana-Farber has often been at the forefront. Even for CAR-T and transplants, Dana-Farber has been delivering more of that care on an outpatient basis. And that's good for patients, and it's also reduced inpatient utilization. Materials provided by Dana-Farber indicate that they've saved the equivalent of 5 beds worth of inpatient care just by doing more of these transplants on an outpatient basis in 1 year, FY24. And so from what we can see, we shouldn't necessarily assume that innovations in care in the cancer space are only going to drive increased inpatient utilization. Next slide. Finally, for future inpatient use, assessment of bed need for the Commonwealth ideally would start with an assessment of current capacity, but oncology beds aren't differentiated in reporting from medical and surgical beds. So we can't actually count cancer beds in the existing data sources. If physical space, as opposed to staffing, is the limitation on inpatient capacity for oncology care, the look at the post-acute care crunch suggests that investing in post-acute care capacity and discharge planning might help to free up existing inpatient space. And we also note that other providers, and specifically MGH, are already working on expanding oncology-focused inpatient capacity. So with all of that, we don't have a definite answer here as to whether the exact scope of what Dana-Farber is proposing is necessary or sufficient to meet future inpatient utilization. And that is the best assessment that we can make. We see a lot of confounding factors here. On the next slide, the CMIR statute instructs the HPC to review the party's role in serving traditionally underserved patients. Literature documents disparities in cancer screening and morbidity and mortality based on patient payer, race and ethnicity, geography, income, and social determinants of health. Looking at the party's current patients, Dana-Farber and BIDMC serve a relatively diverse patient population as compared to the statewide numbers in the oncology space. BIDMC serves a particularly high proportion of Black patients in its oncology service, and DFCI tends to serve a larger proportion of rural patients as compared to other Boston providers. We've covered previously that the proposed expansion would represent a concentration of care in Boston, and that might have access implications for patients for whom travel is a greater burden to care, and highlighting the need, I think, for strengthening community care and coordination and attention to the continued concentration of specialty services in Boston. Next slide. With regard to, so as with quality improvement, the parties currently have programs promoting equitable access to their services. They are forming plans to further expand those programs and collaborate in delivering on them. That includes a working group that's identified priority equity areas and short and long-term planning goals. All of those efforts indicate that there is a potential here to improve equitable access to care. But again, these plans are at the sort of planning to plan stage where the HPC doesn't have enough information to say that we would expect that X, Y, or Z outcomes are specifically likely. The one area that I will flag is that Dana-Farber has publicly committed to improve and align its financial assistance policy to align with BIDMC, which would be a more generous policy, we understand, than Dana-Farber currently provides. And public reporting, frankly, would help assess progress on these plans and keep focus on further development and investment in these areas. So the next couple of slides are summary slides, but I think that given time, it might make more sense to move past them and onto the timeline slide, which David has covered already, and see if commissioners have any questions.
Thank you. Any questions from commissioners?
Can we just move to the slide with the summary of findings for the whole report, please? Or at least the first slide of that. Thank you.
Do you want me to talk through this, David?
No, I think it's just helpful to have this as
great.
And our role today is to decide on whether we vote to release the preliminary report. Commissioner Cutler?
I have one role that I try and fill for us, which is when we do something that's technical economic, I try and indicate to people whether I think the technical part was done right, because obviously that's a subject I'm a little bit more expert in than some of the commissioners. So independent of whatever you feel about the analysis or whatever, I can tell you that as an economist, the analysis is done very well, that, you know, the methodology employed is the right methodology, it's done well. So like any issues we have should not be around kind of, is what's done here done well? I'm not saying how we should feel about it. I purposely want to separate those out, but just as a statement about like kind of, you know, when the malpractice economist looks through things and says, was malpractice committed here? The answer is absolutely not.
Thank you.
So to the accuracy of the facts that we're looking at in the analysis. Thank you. Commissioner Foley?
Thank you. I now feel a lot more confident Dave Cutler gave his ringing endorsement of the models. But very good job, well done. And clearly we've spent some time digging into it and have had a chance to review it. Even though that was a fast presentation, just to be clear, I was able to take some longer time to review and think about it. And just one thing I wanted to raise, and I think was raised when we initially talked about this before having the CMIR, is just the impact on workforce challenges already, that this is going to be a new significant expansion. You know, we talked about the boarding and ERs and the backlogs. It has a lot to do with current staffing capacities and issues. So I'm just wondering if there was any conversation with them in this process about how they're thinking about doing that and its impacts on other providers who are currently, you know, trying everything they can to fully staff their hospitals or their institutions to continue to deliver quality care. Just wondering kind of where that conversation landed. Thank you.
Yeah, the Dana-Farber, the DON program has asked Dana-Farber some questions about this specific point about where they expect to get their new staff, and Dana-Farber has outlined a plan to essentially build new workforce pipeline specifically tailored to training folks who are going to be the next cohort of oncology specialized staff, not only clinical but also you know, management. And so there are details on those initiatives in the parties' DON filings. I also think it's fair to say that the parties have explicitly stated that they don't expect to their plan is not to hire staff away from anyone else. I think nonetheless, yeah, it is a question in our minds, even if they don't hire, specific people, they are going to be competing for that next round of staff who are going to be entering the workforce, and that may have impacts on the availability of those staffs for others and for the labor market more generally.
Commissioner McGregor?
Thank you so much, Sasha. Brilliant presentation, and the preliminary report equally as brilliant. So I have two questions on, well, the first one is on reimbursement status. So you mentioned that Dana-Farber currently is under a sort of exemption with CMS from the prospective payment system, meaning that they're reimbursed on a cost-based basis. Do we know whether or not that'll continue with this new affiliation and new hospital? So with these 300 additional beds, will they be paid by Medicare under a cost-based reimbursement scheme? That's the first question. And I guess you can answer it, but hopefully.
We have seen no indication that is going to change.
Okay, and then will BIDMC fall under that exemption as well?
No, and BIDMC is going, and Dana-Farber will continue as separately licensed entities, and so that doesn't have any impact on how BIDMC is reimbursed by Medicare for any service.
Okay. And then my second question is around really what appears to be sort of a net gain in the number of cancer beds in the Boston area and in the Commonwealth. And, as the previous presentation demonstrated, we have, a dire need for beds across the board in other service lines, behavioral health being one of them, maternity being another one. We've lost several maternity wards in the Commonwealth over the last several years. And there's, somewhat of a way that this appears like kind of an arms race for more cancer beds by some of the biggest players in the healthcare system. And, I just wonder at this point in time whether there's been any discussion of some of the additional beds that remain at BWH or at BIDMC, whether instead of those automatically becoming medical oncology beds or surgical oncology beds, whether they could be swing beds, maybe they could serve the dual purpose of maybe providing post-acute care as well as other types of care that are needed. We see the huge bottleneck that exists between inpatient stays and post-acute care. So just putting that out there because it pains me to think that hospital systems might be competing for these relatively generously reimbursed services at the expense of other needed services.
Commissioner, I'll just add that that is a great observation and a great question. And we would invite the parties to respond to that question as part of their response to this preliminary report. And so I'm sure they are watching intently this presentation, but I think that's a brilliant question to hear from them on.
Thank you.
Other questions? Either for Sasha or, as Commissioner McGregor has done, for the submitting parties? Thank you. And to underscore what Commissioner Foley observed, we did have the opportunity to review the preliminary report. So I know that commissioners have been able to dig into that more fully than we would be able to reflect in this public meeting. If no other questions, can we move to a vote to release the preliminary report?
Motion.
Second.
Okay,
And-
let's do it. Madam Chair,
Aye.
Vice Chair Cohen,
Aye.
Commissioner Castiel.
Aye.
Commissioner Coughlin,
Aye.
Commissioner Foley,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner McGregor,
Aye.
and Commissioner Sullivan. Thank you, Dana. Okay.
Thank you. And we'll look forward to the next steps on this and responses on our preliminary report. Now for our final agenda item, we're going to, recognizing that we're at time, we're going to move to final comments by our executive director, and perhaps you could also comment, David, on how we will issue the advanced guidance, given that we won't have an opportunity to discuss it today.
Thank you, Chair DeVoe, and thank you, commissioners, for again your engagement throughout this process. And I just want to recognize the HPC team that has put tremendous work into this, and specifically Sasha. Great presentation, a lot of content in a short period of time, but this is really important work for the HPC and for the Commonwealth writ large. The last few items that we had on the agenda were really about providing some public notice of some upcoming work and events. The notice that we wanted to provide in this next agenda item was that we have been receiving a number of questions from different healthcare organizations about the expectations of the implementation of the new healthcare market oversight law, specifically with regard to certain types of transactions that may trigger a material change notice. The law expanded the type of transactions that come before the HPC in a number of ways. And that law is going to become effective on April 8th. And so as we've been receiving these questions, parties are wondering what their obligations are going to be to the HPC after April 8th in terms of a requirement to file notice. We think it would be really helpful for market clarity to provide some advanced guidance and to issue that so that market participants have that understanding of what types of transactions will be newly notifiable to the HPC. This presentation just talks a little bit about what the scope of that advanced guidance will look like. We are in the process of developing the very specifics of that. For this purpose, commissioners, that would be something that would be released through the staff and through our office that oversees this. But prior to that, you have my assurances that we will share that guidance with all of you and get your input at a staff to me before we issue that advanced guidance, and more broadly to the public as well. If there are questions that organizations may have, we are open to hearing them because we really intend this guidance to provide clarity. Then the final thing that I want to provide notice of is that our next meeting is our annual healthcare cost growth benchmark consideration of potential modification. So this is our annual event that we hold in coordination and collaboration with the Joint Committee on Healthcare Financing. It is going to be Thursday, March 13th at noon at Gardner Auditorium back in the Massachusetts State House. This is an opportunity for the HPC to receive testimony from interested parties and the public about where the HPC should set the healthcare cost growth benchmark for calendar year 2026. And so we really do invite people to come and to attend this public hearing, and if interested to testify before the board at this time. We also will accept written testimony at the email included here. But we look forward to this important event and important consideration in just a few short weeks. And again, invite the public and other interested parties to attend this public meeting. Happy to take questions on those final items, but also do know that we will be back in touch.
One other note about future meetings, our next HPC board meeting will be held on April 17th at noon, following the benchmark hearing in March.
Correct.
Any other final questions or comments from commissioners? If not, we are adjourned. Thank you all so much.
Thank you.
Thank you.